Friends, and today is a big day because we are again starting up with a clinical pharmacology series and an important topic being covered. I have with me again Dr. Suresh. I welcome him on the show. He has agreed that he will be with us, and it's a great thing because it adds value to how we use drugs rationally when it comes to all clinical therapeutics. So the topic for today is about drugs for ischemia. In which we'll be mostly talking about IHD, the ischemic heart disease, and drugs for angina and so on. So the first take will be from Dr. Suresh, where he will enlighten us about the IHD itself, the ischemic disease itself, what's the magnitude and what are the things, clinical components which come under it. To Dr. Suresh.
Okay. Thank you, Dr. Ameya, for inviting me for this another series of online video tutorials. Today we are going to discuss more on this pharmacotherapy of ischemic heart disease. Ischemic heart disease is a very common clinical syndrome which affects many population worldwide, and it follows any level of critical obstruction to the coronary arteries, and it affects most of the elderly individuals after their age group of 40. Middle age to elderly after the age of 40 years. So it becomes highly essential to know about its pharmacotherapy, their clinical implications, and also their limitations while we are dealing with the management. So here basically we need to tell that any disease process that disturbs the relationship between myocardial oxygen supply and demand can cause ischemia. So that's the main thing. And it depends on the three important factors, this ischemic heart disease. One is impaired coronary artery blood flow, which is caused by coronary atherosclerosis, coronary artery spasm, either sometimes due to aortic dissection where it involves the coronary, the origin of coronary vessel, and sometimes it also follows tachycardia, severe tachycardia causing shortened diastolic phase. That is one factor. The second factor would be impaired oxygen delivery, which may occur due to hypoxia or due to any cause. And anemia is one of the important metabolic, disease, metabolic cause for impaired oxygen delivery. That can also cause ischemic symptoms. The third factor would be increased cardiac load or cardiac work. So where there be any cause which causes increased workload to the heart, such as hypertension or whichever states like thyrotoxicosis, those kind of conditions where it causes increased workload to the heart.
So it's mostly about what happens with the oxygen supply to the heart and some factors which govern the contractility of the heart and so on. So it's a big thing because the magnitude is huge, and as rightly said, it's the disease of the elderly, but to be on the other side, even the young individuals nowadays getting up to IHD because of the obesity factor, the syndrome X and so on. So there's a lot of addition, of course, to this disease.
But moreover, the young people, as far as I see, many young patients, they come presenting with ischemic heart disease due to the risk factor of smoking.
Smoking.
Which they start young at their young age of around 18 years. Sometimes even 16 years also. And they present to
There's
us.
no bar for smoking, right?
There is no bar for. I saw one guy started smoking at around 12 years of age, and he presented to us around 23 or 22 years itself with MI.
So that's becoming an issue, right? So it's no more of a I should say a medical condition, but medical condition which is aligned to cultural issues, social issues, stress factors, stress also. So a lot of things happening.
It's a cycle where stress causing him to smoke, and then increased smoking causing addiction to smoke again, and then causing all these problems later on, ischemic heart disease and so on.
So, as rightly said, this is a disease of all ages nowadays, and a lot of things which can be related to cardiac disease, ischemic heart disease per se. We have several drugs which we can use for ischemic heart disease, and to classify them, we start up with nitrates. Nitrates are the gold standard drug for treatment of ischemic heart disease, and we have short-acting nitrates like glycerin trinitrate, and we have moderate to long-acting nitrates like the isosorbide dinitrate, isosorbide mononitrate, and then the long-actings would be the pentaerythral tetranitrates and so on. So nitrates composite a major group of drugs which are used for ischemia. We also have drugs which we use for prophylactic purposes to prevent any further attacks, like beta blockers, in which are metoprolol, atenolol, and so on. In addition, we also use calcium channel blockers. We have seen a bit on calcium channel blockers and beta blockers when we did about hypertension. So those who are new to this series, maybe you also want to watch our clinical pharmacology series in hypertension, where we discussed a bit on these two drugs group. So we have calcium channel blockers in which we have verapamil, diltiazem, and then more vasoselective calcium channel blockers like nimodipine and nifedipine and so on, which are of course used somewhere down the trend in the treatment of ischemic heart disease. We have a few more additional drugs also which have come up early, I should say in the near past, I should say, for treatment, and has added value to the systems like potassium channel openers, nicorandil. And we have some other drugs which modify basically the metabolism of the heart, like drugs like ranolazine, which is picking up very well as an add-on agent, I should say, for treatment of ischemia. And then of course we have antiplatelet agents like aspirin, which are COX and thromboxane inhibitors. We have the ADP receptor inhibitors like Clopidogrel, and then we have the very recent in antiplatelet agents like the GP2B3A receptor inhibitors like apixaban, a monoclonal antibody which has added value to treatment of ischemia. We also have ivabradine, that's a funny channel blocker. We'll come to this all things, what are these channels and so on, which are of course used in treatment of ischemic heart disease. And then if there is a thrombus, we want to break it, and then we have anticoagulants and thrombolytics like low molecular weight heparin, streptokinase, treatment of pain with opioid analgesics, drugs which can bring down the lipid levels, statins, gold standard ones, and of course which adds to value in treatment as far as survival is concerned after attack, BASA inhibitors, which also have a major role nowadays to play as far as drugs for ischemia are concerned. That was about classification as far as drugs are concerned, but clinically we can just classify them into drugs which are used in acute conditions, basically nitrates, glycerin trinitrate, short-acting ones, and ones which are used for chronic prophylaxis. All other drugs mostly that we just mentioned would be more for prevention of any further attacks. So this was in short about, I should say, the classification. A list goes, it's a big list, and we'll be discussing across all these drugs in detail as far as these things are concerned. Anything to add from Dr.?
So far, I think you have covered extensively about the classification.
Yeah.
I think this should be.
This should be enough. Okay. So the next in the line is antiplatelet drugs. Antiplatelet drugs, as you know, are the gold standard as far as prophylaxis is concerned for prevention of any further attacks of myocardial infarction, of ischemia, let it be angina or any other thing. So the gold standard drug which is used, or which is one of the key drugs, in fact we have 1,000 uses of aspirin till now, so documented uses. So it's a drug which is a miracle, of course, I should say, which is of course an antiplatelet agent also. It inhibits thromboxane synthesis in platelets, and thromboxane A2 is one of the potent platelet aggregate factors. So that is what is inhibited. So it inhibits platelet aggregation. At the same time, you should always remember that platelets lack nuclei. So they are exposed, when aspirin is taken orally, platelets are exposed to aspirin, before it gets metabolized in the liver, in the portal circulation. So even low doses, that's why we always talk of low dose of aspirin, because that's where it all comes to, because even low dose and platelets do get, they are in contact with this kind of aspirin within the portal circulation, and that itself is enough for the thromboxane A2 to get inhibited and inhibit in turn platelet aggregation in general.
But this low dose is not enough for anti-inflammatory?
Yeah, anti-inflammatory. We are talking of a dose which roughly stands 75 milligrams, which is a gold standard antiplatelet dose that we talk of. We are not talking in terms of other effects of aspirin which will come up at the higher doses. So that's what I said, low dose aspirin. Why low dose? Reason being, in portal circulation, before aspirin gets metabolized, it gets in contact with the platelets, and that's why low dose is what is, I should say, beneficial in all these cases.
This dose will not be optimal for analgesic or
definitely not.
Anti-inflammatory.
Definitely not. Definitely. It has also been seen that if you take aspirin for a very long time, it even decreases synthesis of clotting factors in the liver. Now that's a minor element, but you need to take aspirin for a very long time if you are wanting to have this kind of effect. Now remember that if you increase the dose of aspirin, that's what we're talking of, and if you take it on a chronic use, then even it has the ability to block the prostaglandin synthesis within the intimal cells of the endothelium. Now that is actually contradicting with the fact that it is exactly the opposite of what should happen, because prostaglandin is one of the potent inhibitors of platelet aggregators. So you block that synthesis at higher doses. Now it's going to be a reverse manner. So that's why also we use low dose aspirin to extend to block all these platelets, and that's where it all comes to when formation of thrombus and clot is concerned. We should say that platelets are essential, I should say, in management of prophylactic purposes, but they are also being used in acute management of angina also, to extend basically unstable angina, where we want the things to happen, and where the risk that a patient can go into MI, we can use aspirin. Now remember that if the patient is taking aspirin for a very long time, he has certainly chances of getting gastritis, because aspirin is absorbed by the duodenum. It's a weakly acidic drug, so it gets absorbed not from duodenum, from the upper GIT, I should say, basically the stomach. But there is some kind of ion trapping which happens within the cell walls of the gastric cells. So what is that? Is that it gives rise to toxicity of aspirin. Now why ion trapping? Because inside the cell it is not that acidic. Okay, so acidic drug, when you keep it in a basic medium, it gets ionized and is unable to absorb fully into the bloodstream. So some aspirin gets trapped, and that's the reason that effects like gastritis come up eventually. So it's the ion trapping effect of aspirin that is important. It can also give rise to certain other things like hypersensitivity, which is very rare, but you can see it. Of course, toxicities with low dose aspirin is not that a worry, but definitely with high doses aspirin that can be seen.
Like Ray's syndrome.
Yeah, but anyway, we don't use this, so won't be talking of that now. Displacement reaction with other drugs, especially Warfarin and so on, are there with aspirin. It nullifies actions of diuretics, and you should remember that platelets are unable to synthesize the enzymes once again because they lack nuclei, and this is an irreversible inhibition of thromboxane A2. So it will take at least 7 days for the platelets to again come back to normal level. So that's one important, because you cannot just you need to stop aspirin at least 7 days before getting into any kind of operation. So that's the reason. Anyway, it has nothing to do with antiplatelet, but since it is all tackling with these enzymes, I need to tell you that you need to at least give 7 days for the platelets to come up with another new series synthesis, and then again the entire thing. So that was on aspirin. Anything to add from your side?
I think nothing more. Whatever you covered is extensive.
Yeah.
Aspirin.
Yeah. The next drug is of course Clopidogrel. Now it goes in line with another drug like ticlopidine, but we don't use ticlopidine because it has a lot of side effects. So I mostly talk of Clopidogrel because that's again a good antiplatelet agent. It inhibits ADP receptors as well as it will inhibit indirectly fibrinogen-induced platelet aggregation. So that is how it acts. It actually alters the cell surface receptors, that is the ADP receptors, as I told you. That's the way it acts, and it's better. They say in some studies they say that it's better than aspirin preventing primary ischemic attack. But then there are few side effects. Otherwise a tolerable drug, I should say, but there are few side effects of Clopidogrel like bleeding, which is important effect with Clopidogrel. Some other things like neutropenia, thrombocytopenia, bone marrow issues, skin rash, diarrhea, hypersensitivity are there with Clopidogrel. But usually these side effects do not come in all the patients, and it is mostly a safe drug, I should say. For patients who cannot tolerate aspirin, Clopidogrel becomes a good option. It's a good option. You have certain combinations also of Clopidogrel and aspirin. Some FDAs do approve it, but then remember that they can induce bleeding. So there is a chance that you can, actually induce bleeding. But then again, there would be clinical scenarios where you want to use that.
Yeah.
So
especially the stented patients.
Stented. So you want to weigh the risk and the benefits before you can go up to using both the drugs, and you need to see that the condition of the patient and disease and so on before you need to put up all those things together for the patient. The effects of the drugs last for 7 days, and I should say that's where these two drugs lie. We can use aspirin in so many conditions like stable and unstable angina, post-MI, but we'll be talking more about that once we are up to the prescriptions for these conditions. I leave it to Dr. Suresh to talk more on anticoagulants. That's the next group of drug. To Dr. Suresh.
Thanks. Anticoagulants, they are the main class of drugs when we deal with the treatment for unstable angina. The main anticoagulant which we have to talk first is the conventional heparin or unfractionated heparin, which is a powerful and quickly acting anticoagulant. And the main mode of action, it acts indirectly by activating plasma antithrombin 3. So this plasma antithrombin 3, they form a complex with heparin, and it binds to the clotting factors of intrinsic pathway and then common pathway like 10A, 2A, 9A, 11A, 12A and 13A, and inactivates them, but not the factor 7A. Okay, except 7A, all the other factors are inactivated by this heparin antithrombin 3 complex. Okay, and this action is exerted mainly by the inhibition of the factor 10A. Okay, factor 10A is the one which is responsible for conversion of prothrombin to thrombin. Okay, so if that conversion is inhibited, then the whole process of coagulation is being prevented or being lysed actually.
Yeah.
So that thing is the main step here, which is done by this heparin. And not only that, it also inhibits the thrombin-mediated conversion of fibrinogen to fibrin. So there are two steps, critical steps, which are inhibited by heparin. One is, as I told you before, the conversion of prothrombin to thrombin, and then conversion of fibrinogen to fibrin. The advantages, if you talk about advantages of heparin, there are a lot of, not only in unstable angina, it can cause an antiplatelet action in higher doses, not only as an anticoagulant but also can be used as an antiplatelet, and it has got a lipemia clearing action here, which many of us may not highlight may not remember, though we have studied theoretically in younger, in the early days of our undergraduate course. And it is the best drug for anticoagulation during pregnancy, because of various reasons for not using our Warfarin, though we can, because of its teratogenic effects. So heparin has no teratogenic effect, so it is the best drug of choice for anticoagulation during pregnancy. And not only that, it doesn't. The reason being, it doesn't cross the placental barrier, blood placental barrier.
Yeah,
Even
important.
the blood-brain barrier, it won't cross. And not only that, it has got a strong beneficial effect in preventing deep vein thrombosis, and later on, from there, it will prevent pulmonary embolism in all the high-risk patients. Those who have hypercoagulable states, those who are prone for recurrent thromboembolism, this is the best drug to begin with, and can be maintained with the initiating or maintained by Warfarin treatment. And it is being widely used, as I told you before, it is a widely used drug in the treatment of unstable angina and non-ST elevation MI, since it decreases the incidence in these patients for the recurrent attacks. Then if we talk about the adverse drug reactions, bleeding is the only main
we are worried about.
we are worried about this problem, this drug, bleeding due to the overdose. And moreover, this can be prevented by monitoring the APTT level. And if at all the bleeding, when it happens, the hematuria is the main first sign. We need to look for hematuria. And heparin induced thrombocytopenia. Some people used to call it as HIT, heparin induced thrombocytopenia, HIT. It's another complication which is mildly seen. Sometimes it occurs transiently, and it is mainly because of aggregation of platelets. So it just pulls all the platelets together, and thereby it causes thrombocytopenia in the other areas. And many of us may not know, if you use heparin for a longer time, there may be a transient alopecia seen. And osteoporosis also.
Is skin necrosis.
Yeah, skin necrosis, where warfarin also can cause that skin necrosis, but it also seen in with heparin usage. And hypersensitivity is rarely seen with heparin. So, but not only that, in the medical treatment, this heparin can be used also to withdraw the samples, blood samples. And to prevent.
So it's also a lab medicine.
Lab medicine. So that's another very well known advantage for heparin. Contraindications. If you look at the contraindications, all the bleeding disorders, it's better not to consider this drug. And of course, in thrombocytopenia, because when you use the heparin, it can further decrease the platelet count. And also in case of severe hypertensive patients, because of risk of intracranial bleeding is more. So severely hypertensive patients, for example, if they have blood pressure of more than 180 by 100, then it is, stage 2. So then it is better not to consider giving this drug. And the threatened abortion, piles, hemorrhoids, GI ulcers, the frequent or recent history of GI bleeding.
In fact, that's again a contraindication to use aspirin also.
So aspirin and heparin both are contraindicated in recent history of GI bleeding. And risk of embolism, those who have high risk of embolism, such as bacterial endocarditis, the malignancies, because they may have bleeding inside the central area of it may cause centralized necrosis inside the malignant tumor lesions. So, and then tuberculosis, because of risk of hemoptysis, because already there may be Rasmussen's aneurysms, and when you give heparin for a longer time, it can induce the rupture, and it can cause hemoptysis. And better not to consider in ocular or neurosurgery, because, and moreover during when you plan for lumbar puncture, you need to be really cautious about the usage.
In fact, where there are chances of bleeding,
Yeah,
you should
wherever there is,
from.
yeah. And then chronic alcoholics,
Yeah.
or because their liver will be already under dysfunction, cirrhosis, cirrhotic patients, renal failure, where there is already thrombocytopenia and platelet dysfunction will be there. And along with aspirin, it should be used cautiously, considering the complication of bleeding. Then the dosage, usually it is given subcutaneously for prolonged anticoagulant effect, because sometimes if you want to give, we can also give as a IV bolus to start with, and then later on maintained by subcutaneous administration. And moreover, to the fact that it is never absorbed orally, that's the reason to have a prolonged effect also. The dosage is usually 5,000 units to 10,000 units for every 4 to 6 hours, and the lower dose for DVT and pulmonary embolism prophylaxis, and the higher doses for treatment of unstable angina or non-ST elevation MI, and also for primary treatment of deep vein thrombosis and pulmonary embolism. The next category of heparin anticoagulant drug is low molecular weight heparin.
Before we go up to, I need to just add, since I just remembered something, is about, heparin is an acidic drug. It's one of the most acidic substances found in the body. So in fact, patients who have heparin toxicities, we treat that with a very basic antidote, which is a protamine sulfate. So it comes from the very basic elements of the nature. So that's how we tackle heparin toxicities, especially when we get that to clinical side. So just to add on, it's most acidic, so need to titrate it with the basic one. So protamine is one which comes from, they say, fish sperm, so more alkaline and so on. So that is what just comes to my mind. Just add on. Just something interesting, yeah. Okay, low molecular weight heparin.
Yeah, next is the widely used low molecular weight heparin. Because of various reasons, it is because of less complications when compared to conventional heparin. There are a lot of preparations of low molecular weight heparin, like enoxaparin, reviparin. Enoxaparin, which the trade name which we use here, in many places, Lexane. Reviparin is Clivarin, Nadroparin is Fraxiparin, Dalteparin is Fragmin, Pamparin as Fluxum, and Atriparin as Intriparin. Mode of action, this heparin has been fractionated into this low molecular weight forms by various techniques, and this has a different anticoagulant profile, and they act by inducing conformational change in antithrombin 3 and not bringing together this antithrombin 3 and thrombin complex. What is the main advantage of this low molecular weight heparin over this conventional heparin? Because here they don't affect the APTT, activated partial thromboplastin, and so no need for frequent monitoring of this prothrombin time and APTT levels. So that is a main advantage. And so once you inject this subcutaneous low molecular weight heparin, the patient will not have any bleeding, less chance of having bleeding complication, and no need to monitor also. And they have, this group of drugs, they have lesser antiplatelet action and less frequent thrombocytopenia and lower incidence of hemorrhagic complications, as I told you before, and better subcutaneous action and distribution also, bioavailability. And they have longer T-off, so once daily administration is very
and they come as pre-filled syringes.
Pre-filled syringes, so easy
administration.
user friendly. And that's, so in many ways
it's much better than, in fact, now the use of heparin has gone down, conventional heparin. you see always this low molecular heparin coming up, less bleeding chances, given sub-Q, pre-filled syringes. So a lot of advantages. Monitoring is less as compared to heparin and so on. Very specific action. That is also.
Yeah.
Yeah.
Only thing is bit expensive.
Bit expensive.
Than conventional.
But nowadays that cost has been absorbed in the medical profession as such.
Yeah.
Okay. Yeah.
And the indications is almost the same as we have told before for conventional heparin, for DVT, pulmonary embolism, unstable angina, non-resting elevation. Of course, it is the main drug. It has replaced the conventional heparin.
Yeah.
There's no molecular weight heparin. And even now they use this drug in shunts. When they want to clear the shunts in dialysis patients, and to maintain the patency of cannulae, IV cannulae, and also the shunts in dialysis patients, and also in extracorporeal circulation. So it is a extensively used drug. And a few words about Fondaparinux. This is nothing but a pentasaccharide with specific sequence that binds to antithrombin 3 complex with high affinity to inactivate factor 10A. This has been recently produced synthetically and given this name as Fondaparinux. And a few word about oral anticoagulant, with the one and only.
Yes, Warfarin.
Warfarin. So, which is being widely used, commonly used for long-term management. Once you initiate with conventional or low molecular weight heparin, then for long-term use, this is the best drug.
Yeah.
Because we cannot use heparin for longer time.
Yeah.
Because of various side effects and limitations.
Yeah. Warfarin is oral.
Warfarin is oral, so easy to take. Easy to administer, but it has got other limitations also, which we will talk about later.
Yeah.
Indications are same for all the long-term management for all the conditions which we have discussed about DVT.
So all ischemic.
All the ischemic conditions.
The only thing that you need to know about Warfarin is that Warfarin will be inhibiting all the vitamin K dependent clotting factors. So that's one important point clinical pharmacology that they need to know. As far as Warfarin, it's orally, whereas all other heparins would be mostly by parenteral route. So there are limitations for its use, Warfarin, but Warfarin again comes with its own interactions, drug interactions. So it's not, I should say, there is a list of interactions, drug interactions, side effect profile of Warfarin is bigger than, I should say.
That's a main problem with Warfarin.
Main problem with Warfarin.
Teratogenic.
And you also need to monitor Warfarin with INR and so on. So I mean, there are issues with Warfarin also, but since we are just talking about ischemia, it's good to talk just in few sentences about Warfarin. Anyway, the role of Warfarin as far as acute management is concerned is nowhere there.
But only for the
chronic management of
this, DV thrombosis, deep vein thrombosis, and other thrombotic conditions. So some few anticoagulants, other oral apart from Warfarin, other oral anticoagulants are there, like acinofumarol, bis-hydroxycoumarin, phenydiol, like those drugs are there.
Yeah.
So not only that, these group of drugs can be used in high risk conditions for arterial clots like prosthetic valve. Okay, any patient who has atrial fibrillation, this is the best drug, and one of the common indication for Warfarin usage in atrial fibrillation and those who have prosthetic heart valves.
Yeah.
So, just few words about this
Warfarin. Yeah, it was quite a good information on coagulants, heparin, and a few words on Warfarin. The next class of drug is on the new drugs which are picking up and which are used extensively nowadays is again antiplatelet agents which are glycoprotein 2B3A receptor antagonists. The basic drug would be apixaban. Now remember, it's a monoclonal antibody and it is not that antigenic as compared to the other ones. It is basically glycoprotein 2B3A is an adhesive receptor for fibrinogen and 1 billion factor. It gives rise to aggregation of platelets in a clot form. So you block that thing and you are blocking up the platelet aggregation. It is actually platelet aggregation is inhibited in around 12 to 24 hours after giving once you give apixaban. There are a few side effects which are associated with use of apixaban, that is hemorrhage, thrombocytopenia, and a few GIT side effects are also noted with apixaban. It is used in unstable angina and it is also used along with aspirin and heparin for placement of stent in these patients. It is given as IV agent in a dose of around 0.25 milligrams per kg for the first hour, followed by 10 microgram per minute for the next 12 hours. There are a few alternatives to apixaban which are also monoclonal antibodies. The ones important would be the tirofiban, and the other one would be FT-fibatide, quite a tricky name as far as
FT-fibatide.
Yeah, FT-fibatide. So you need to know about these drugs also when you talk of glycoprotein 2B3A inhibitor, which aggregates platelets along with the help of fibrinogen. So I leave it to Dr. Suresh to talk about the next class of drugs. That's about thrombolytics. The basic one would be streptokinase and so on. There's a big list, so, so to Dr. Suresh.
Thrombolytic, that is the main drug, the core drug which is going to lyse the thrombus, the big thrombus, which is already organized, and then it is occluded the coronary vessel. So after giving the aspirin, heparin, when in case of myocardial infarction, heparin is just given only for prevention of deep vein thrombosis, and also to prevent further pulmonary embolism in case there is deep vein thrombosis. After aspirin, the main drug to take effect and to cure or sometimes even to lyse the whole clot is the streptokinase, which is a thrombolytic drug. And if you take the mode of action of this streptokinase, it is obtained from Streptococcus, the group of beta hemolytic streptococci, especially the group C one. So that is the source of this drug. And usually from the beginning it is inactive, and once it combines with circulating plasminogen, then it forms an activator complex which causes proteolysis of other molecules, plasminogen molecules, to a plasmin. So this plasmin is the one which lyses the whole organized clot, the thrombus. So, in order to initiate the whole process of events, we need to give a loading dose that is more important to overcome any anti-streptococcal antibodies which may be present due to past infections with the streptococcus. So, the only problem is sometimes if it is already being used, we cannot use this drug. So for the recurrent or the recurrent myocardial infarction patients, this cannot be used again. So because of this problem of anti-streptococcal antibodies, and indications as we know that it is the best and inexpensive, very cheap drug when compared to the other group of drugs. So for reperfusion therapy of myocardial infarction, and even sometimes massive pulmonary embolism due to deep vein thrombosis or of any cause. So this is the best drug to cure this group of patients. When we talk about the drug interactions of this drug, and then adverse drug reactions, limitations, since it is antigenic, it can form antibodies, and it can also cause hypersensitivity reactions. And sometimes it may cause anaphylaxis also. That is the worst complication of streptokinase. So when you are giving this drug in the ICU, you should always keep monitoring and expect this complication of anaphylaxis. So it's better to start with a test dose before you give this loading dose of streptokinase. So that is very, very important complication. Suddenly the patient can go into anaphylactic shock, and his condition may worsen. Already he may be under the effects of sympathomimetic effects of myocardial infarction. When you give this drug, you need to monitor and expect this complication of anaphylaxis. And especially this complication may happen when there is a chance, when you don't know the history of this same drug being used before. So because the antibodies already, this drug is an antigenic, so antibodies already formed. So there is a high chance of anaphylaxis in those patients whom they received this streptokinase before. And moreover, when you repeat the dose for another time, there is less effect. The drug is not so effective, and because of the neutralization of antibodies. And other less common side effects include fever, sometimes chill strikers, fevers, rash because of the allergic, sensitivity, hypersensitivity, allergic rash. Sometimes, of course, due to anaphylaxis, the patient will go into severe hypotension. So the one main complication which we watch for is hypotension following streptokinase administration. And the cardiac complications due to this drug may be sometimes the patient will develop ventricular tachycardia or any form of arrhythmia. So we need to monitor the patient closely with all these problems. The other drug which is used in case if the streptokinase is already being used for the next or when recurrent MI, we can consider using urokinase. Urokinase, it's just an enzyme isolated from human urine, and nowadays it is prepared from cultured human kidney cells. This also activates plasminogen directly and has got a plasma T-half of 10 to 15 minutes. And this is
basically it's non-antigenic, less antigenic,
compared to streptokinase. So we cannot expect this anaphylaxis, allergic reactions when you use this drug. And sometimes fever happens. Fever occurs when you use this drug. But the other complications of hypotension, allergy, anaphylaxis, as I said before, they are very rare. So as I told you, this is the best drug to replace streptokinase in those who have been used with the SK before. And but the usage of this drug urokinase is now declining because of the introduction of Alteplase, the newer fibrinolytics. The newer fibrinolytic which I am going to talk about now is Alteplase or RTPA. In short, they used to call it as RTPA, which is nothing but recombinant tissue plasminogen activator. The mode of action and advantages of this drug, it's derived from recombinant DNA technology from human tissue culture. And due to this, it is this process, the whole synthetic process, since it is derived from this, it is very, very expensive when compared to the streptokinase and urokinase. And this specifically activates the gel phase plasminogen, which is already bound to fibrin. And this has got little action on the circulating plasminogen. So that's why, since it is not acting on the circulating plasminogen, this doesn't cause bleeding in other sites. So it will act only in the plasminogen which is already bound to the fibrin complex.
Something which directly relates to the clot.
So it will act on the clot area only, the plasminogen which is bound to the fibrin. Okay, so that is the best, very good advantage over the streptokinase. So very, very minimal chance of bleeding in other systems, in other areas like brain.
So we are concerned with intracranial bleeding, GIT bleeding and so on.
Because if there is such complication, then the patient prognosis will be very bad.
Very bad.
Moreover, it is rapidly cleared by liver and has got a plasma half-life of 4 to 8 minutes only. And so because of this short off-life, it should be given by slow IV infusion, and it often requires heparin co-administration. And side effects, when you talk about side effects, though it is non-antigenic, sometimes it may cause nausea, hypotension. Very rarely it may cause fever. The only problem is it's very, very expensive. I mean, the only disadvantage is expensive drug. And the other preparations other than Alteplase or Ateplase, Ateplase, and so on. So
that was a list of drugs. In this session of drugs for ischemia. I think extensive thing has been done by both of us. We talked about antiplatelet agents, Aspirin, Clopidogrel, then going up to even 2B3A inhibitors like Apixaban. And then we had extensive review on anticoagulants, starting with heparin, conventional heparin, low molecular weight heparin, a short note on warfarin, which is oral anticoagulant, and we ended up with thrombolytics, basically streptokinase, and the related list. So I hope you like this session.